So, if you break your arm, you go to the doctor, they take an x-ray, and you get this very satisfying, clear, jagged white line, right?
Right, yeah. It's totally binary, broken or not broken.
Exactly. The doctor points at the film, says, there it is, puts a cast on it, and you're good. But what happens when the pain you are experiencing feels like an absolute five-alarm fire, but the doctor just looks at you and says, I don't see anything wrong?
Yeah, that's the reality for a staggering number of people. It's the absolute definition of diagnostic muddy waters.
It really is. Today, we're looking at a condition that affects up to 28% of women, where the pain is entirely invisible to the naked eye. But it's severe enough to, like, literally rewire the brain.
And for decades, patients with this have been navigating a medical system that relies so heavily on visual confirmation. So when a standard exam doesn't show an infection or some glaring abnormality, the default assumption was just, well, it must be psychological.
Which is just wild to think about now. But thankfully, we are finally moving past that dark age. Which brings us to the core mission of today's deep dive. We are unpacking vulvodynia.
Specifically, localized provoked vestibulodynia, or LPV.
Right, LPV. And just to give you all a clear picture, the International Society for the Study of Vulvovaginal Disease defines this as chronic discomfort in the vulvar vestibule lasting at least 3 months. And this happens without a clear infectious neoplastic or neurological cause.
Yeah, it's severe pain triggered by just a really light touch.
Exactly. But if you're listening to this and dealing with LPV, you probably have a very specific fear, and it's the main question we're going to answer today.
The big one.
The big one. If the skin in that area is already highly reactive and burning, doesn't treating it for something like vaginal dryness with a topical cream act like throwing gasoline on a fire? Like, does treating the dryness actually hypersensitize the nerves and cause more pain, or does it actually help?
It's the pivotal question. Because, if you have an area of the body that screams in pain when touched, your most basic human instinct is to avoid touching it at all costs.
Oh, 100%.
So the idea of deliberately applying a topical hormone therapy sounds completely counterintuitive. But to understand why the biology tells a totally different story, we have to look at what's physically happening to those nerves on a microscopic level.
Okay, let's unpack this, because as I was going through the clinical data for this deep dive, there's this concept called allodynia.
Right, allodynia.
Which is basically when you experience pain from a stimulus that shouldn't be painful at all. It's like the body has turned into a hypersensitive car alarm. A single dry autumn leaf falls on the windshield, and suddenly the horn is blaring, the lights are flashing, the engine is immobilized.
That is a perfect analogy. It's a profound overreaction of the nervous system. A completely harmless touch triggers a catastrophic threat response.
But why? Like, what is actually happening?
Well, the crucial thing to understand is that this isn't a software glitch in the brain. It's a hardware problem in the tissue itself. You take a biopsy of the vestibular tissue from a woman with LPV and put it under a microscope, the physical architecture is fundamentally altered.
Like, you can actually see it.
Yes, you see an aggressive physical proliferation of what are called C-fiber nociceptors.
And just to clarify, nociceptors are those specific nerve endings that detect damage and transmit pain signals, right?
Exactly. They're the alarm sensors. And in a healthy vestibule, these nerve endings are distributed in a specific, controlled density. But in LPV, the tissue is literally hyper-innervated.
Hyper-innervated, so it's overgrown.
Yeah, it has grown a massive tangled web of new pain-sensing nerves. You essentially have 10 times the number of alarm sensors crammed into the same exact square footage.
Wow. But nerves don't just, decide to sprout like weeds on their own. There has to be some biological construction crew building those pathways, right?
There is, and the mechanics of it are frankly astonishing. It comes down to a specific type of cell called a mast cell.
Okay, mast cells.
Normally, mast cells are like the bouncers of your immune system. They hang out in connective tissue, they help with wound healing and defending against pathogens. But in women with LPV, these mast cells go completely rogue.
Rogue how?
They start degrading and releasing this enzyme called heparinase.
Heparinase. Okay, I need a visual for that. What is that enzyme actually doing in the tissue?
Think of heparinase as a chemical bulldozer. To really get its impact, imagine the skin as a two-story house.
Okay, a two-story house. I'm with you.
The nerves are supposed to stay firmly down in the basement, an area we call the basal membrane. Above that basement is the ceiling, which is a tough layer of connective tissue. And then above that is the living room, the surface epithelium that actually comes into contact with the outside world.
So the nerves are supposed to be protected way down in the basement.
Yes, exactly. But the heparinase bulldozer comes in and completely destroys that connective tissue ceiling.
Oh, wow.
Yeah. By clearing that physical barrier, it allows those hyperactive C-fiber nerve endings to just grow upward. They penetrate through the basal membrane and reach all the way up into the surface epithelium.
So the pain nerves are brought right up to the surface layer of the skin.
Immediately exposed to the elements, yes.
No wonder the lightest touch feels like a 5-alarm fire.
Yeah.
You are directly stimulating raw, exposed nerve endings. But hang on, I need to pause you there for a second.
Sure.
If this is a highly localized issue, like just nerves in the vulva overgrowing and reaching the surface, why are we seeing medical data analyzing fMRI brain scans for this condition? Like, is the brain actually structurally changing, or is it just lighting up because it's processing so much pain?
You're touching on the real tragedy of chronic pain here.
Uh,
It doesn't stay local. The brain is neuroplastic, which
Huh.
it adapts to whatever inputs it receives most often.
Right.
So when you have exposed C fibers constantly bombarding the spinal cord and the brain with these catastrophic pain signals, the brain undergoes a process called central sensitization.
Meaning the brain basically learns to become more sensitive.
It essentially rewires its own circuitry to expect pain. And those fMRI results you mentioned, they show that this isn't just a temporary change in activity. The actual physical structure of the brain adapts.
Wait, really?
Yeah. In young patients dealing with this chronic pain, the density of the brain's gray matter actually increases in areas related to stress and pain regulation.
The gray matter gets physically denser. How does that even work?
Think of it like a muscle. If you're constantly doing bicep curls, your bicep grows.
Mm.
If the brain is constantly forced to process severe pain signals, it builds more neural pathways, more cellular infrastructure in those specific processing centers.
That is wild.
It is. Interestingly, in older patients with long-standing pain, we sometimes see a decrease in gray matter. It's almost as if the system eventually just becomes exhausted and atrophies.
Wow.
But the ultimate takeaway is that the local tissue problem creates a systemic brain problem. The brain and the local tissue get locked in this devastating feedback loop, amplifying even the slightest touch into total agony.
Which brings us right back to our listener's core question. We've got a physical overgrowth of exposed nerves, and we have a brain that has grown extra dense gray matter just to process the pain from those nerves.
Right.
So if you're listening to this, you're probably thinking, my skin is on fire. Any touch is excruciating. Applying a topical estrogen cream for vaginal dryness sounds like a guaranteed way to make this hyperwired system just explode.
And it is a completely logical fear. The instinct is to protect the area from any external interaction whatsoever.
Exactly.
But we have to look at what estrogen deficiency actually does to this specific tissue. When a patient experiences low estrogen, whether from menopause, certain birth controls, or postpartum, changes the vaginal and vestibular tissue undergoes atrophy. It becomes dry, thin, and really fragile.
It essentially loses its structural integrity.
Precisely. And remember that two-story house analogy.
Yeah, the basement and the living room.
When the tissue atrophies, the surface epithelium shrinks and thins out. This actually brings those nerves even closer to the surface.
Oh, I see.
Furthermore, biological data shows that estrogen deficiency is intrinsically associated with an increase in sensory nerve density in the genital tract. When the tissue is starved of hormones, it seemingly tries to compensate by growing more nerves.
Okay, this is where a specific 2012 study by Grabling, Liao, and Smith really caught my attention in the source material because it completely flipped the assumption that treatments would irritate the area.
Oh, absolutely.
They looked at postmenopausal women and found that administering hormone therapy, both systemic and topical, actually reduced the density of the vaginal innervation.
That study is a total cornerstone in understanding how to reverse this condition. By applying topical estrogen to treat the dryness and atrophy, you aren't irritating the nerves, you are restoring the health, thickness, and elasticity of the tissue.
You're rebuilding the house.
Exactly. You are essentially rebuilding the ceiling that the heparinase destroyed.
You're plumping the cushion back up so the nerves are buried again.
Yes. The estrogen signals the tissue to regenerate. It increases blood flow, promotes the production of collagen, and crucially, it tells those proliferating nerve fibers to retreat.
Wow.
This is why applying local estrogen is listed in modern clinical guidelines, not as a painful irritant, but as a primary desensitization step.
So for anyone listening and hesitating to use a prescribed localized estrogen because of the pain, treating the dryness is actually a direct step toward healing. You are actively helping to calm the nerves down and rebuild the tissue's defenses.
You're putting out the fire, not starting it. You're addressing the microenvironment, that allows those nerves to thrive in the first place.
Okay, that makes complete sense for patients dealing with estrogen-linked atrophy. But what about the women who develop this without an estrogen deficiency?
That's the other side of the coin.
Right, like if hormone loss isn't the only trigger, what else prompts these mast cells to suddenly go into overdrive, release that heparinase bulldozer, and invite the nerves to the surface?
To answer that, we have to look at what historically sets off the immune system's alarm bells. And the medical literature heavily points to recurrent, localized inflammation.
Inflammation.
Yeah, this is often linked to a history of severe allergies or recurrent infections.
This was such a wild connection to see. When you look at the medical histories of patients with LPV, there is a massive statistical overlap with things like chronic hives, severe localized reactions to insect bites, and intense seasonal allergies.
Right, their immune systems are essentially already walking around with the safety off.
Primed to overreact. And then you introduce a localized trigger, and the most common one in the sources: recurrent yeast infections, Candida albicans.
What happens at the cellular level when you combine a primed allergic-leaning immune system with a yeast infection is quite startling.
Yeah, tell me about that.
Researchers actually conducted a brilliant experiment to isolate this reaction. They took vulvar fibroblasts. These are the primary connective tissue cells that build the structure of the vestibule from women diagnosed with LPV. They cultured these cells in a lab and then challenged them by introducing live yeast species.
So they essentially recreated a yeast infection in a petri dish. What happened?
The cells produced an explosive spike in pro-inflammatory mediators. Specifically, we're talking about molecules like interleukin-6 and prostaglandin E2.
Let's ground those terms for a second. What are those molecules actually doing?
They're chemical distress beacons. Interleukin-6 is a cytokine that tells the immune system we are under heavy attack, send reinforcements immediately.
And the other one?
Prostaglandin E2 causes intense local swelling, redness, and drastically lowers the threshold for pain. When the fibroblasts from LPV patients were exposed to yeast, they pumped out these distress beacons at wildly exaggerated levels compared to cells from women without LPV.
So the yeast didn't just cause a mild irritation.
No, it triggered a full-scale immune system meltdown.
And that meltdown is the catalyst for the nerve growth. Because there was this study involving a mouse model that really cemented the cause and effect of this entire process for me.
Oh, the allergen study.
Yeah. Researchers took female mice and applied a chemical allergen directly to their labia. As you'd expect, the mice developed a severe, localized inflammatory reaction. They swelled up, showed signs of distress. But the crucial part is what happened after the visible swelling went away.
That mouse model is vital because it definitively proves causality. When the researchers later examined the tissue of those mice histologically, they found clear, undeniable evidence of nerve growth proliferation. The initial inflammation acted as a hit-and-run driver.
The hit-and-run driver. That is exactly it. The inflammation, whether it's from a bad reaction to an allergen or a severe yeast infection comes in, triggers the distress beacons, which wakes up the mast cells, which release the heparinase, which allows the nerves to grow to the surface.
Exactly the cascade.
But then the initial trigger vanishes. The yeast infection is cured with an antifungal. The allergic reaction naturally fades away.
But the architectural damage is done. The primary inflammation is entirely gone, but it leaves behind a permanent web of hypersensitive exposed nerves.
So the car alarm has been permanently rewired to be too sensitive, even though the person trying to break into the car left like weeks or months ago.
Which perfectly explains why it's so frustrating for patients to get a diagnosis. By the time the patient seeks help for the severe pain, the clinical signs of inflammation are invisible to a doctor's naked eye.
Right. There is no yeast left to swab. There is no red swelling to point to. The doctor is looking for the fire, but they should be looking for the microscopic smoke damage.
That is the tragedy of the traditional diagnostic model.
Yeah.
It relies on finding an active pathogen. But in LPV, the pathogen is long gone. You are dealing strictly with the anatomical aftermath.
So we know how the alarm gets tripped by inflammation. We know how the nerves physically move to the surface. And we know that the brain builds extra gray matter to process the pain. Now, the million-dollar question: how do we turn the car alarm off?
Right.
How do you actually treat a system that is this heavily compromised?
Well, because the condition is entrenched in both the local tissue and the central nervous system, there is no single magic pill.
You can't just take an ibuprofen.
No, you cannot take an ibuprofen and expect to reverse gray matter density or dissolve nerve bundles. The approach has to be multidisciplinary, and it typically moves sequentially from the least invasive options to the most invasive.
Looking through the clinical data, the interventions are incredibly varied, and they attack the problem from completely different angles. For instance, a very common first-line treatment is the overnight application of a 5% lidocaine ointment.
Yes.
And this isn't just about giving the patient a few hours of numbness so they can sleep, is it?
No, not at all. The lidocaine is highly strategic. By consistently slathering the area in a numbing agent overnight, you are artificially blocking those C fibers from firing.
You're cutting off the signal.
Exactly.
Hmm.
You are cutting off the constant stream of pain signals to the spinal cord and the brain. It gives the central nervous system a much-needed reboot, allowing the central sensitization to slowly begin dialing down.
So you're forcing the brain to unlearn the pain. And then you have neuromodulating medications, things like topical gabapentin or amitriptyline. Right. Normally, if you hear amitriptyline, you think of an oral antidepressant. If you hear gabapentin, you think of an oral anticonvulsant used for seizures. But here, they're compounded into topical creams.
Because the mechanism of action is exactly what we need locally. These drugs work by calming erratic electrical firing in the nervous system.
Okay.
When applied directly to the vestibule, they act like a dampener on those exposed nerve endings, stopping the static electricity that keeps triggering the pain response.
But we also have to talk about the collateral damage to the muscles. Because if your body is in severe pain every time you sit down, wear tight pants, or attempt intimacy, your body's natural defense mechanism is to physically brace for impact.
Oh, absolutely. Many women with LPV develop extreme hypertonicity in their pelvic floor muscles.
The muscles just go into a chronic, severe spasm.
And this muscular guarding actually restricts blood flow to the tissue, creating a hypoxic environment, a lack of oxygen that makes the nerve pain exponentially worse. It's a secondary pain generator.
So how do you break that cycle?
To break this specific cycle, the literature strongly supports interventions like physical therapy focused on the pelvic floor to manually release the tension. And in stubborn cases, doctors use botulinum toxin, Botox injections, directly into the pelvic floor muscles.
Literally paralyzing the muscle spasms so the tissue can breathe and the patient can participate in physical therapy without agony. That makes so much sense. There's also this newer technology showing up in the clinical guidelines, dynamic quadrupolar radiofrequency, or DQRF,
Yes.
which sounds like something out of a sci-fi movie.
It is a fascinating application of technology. DQRF uses highly targeted radiofrequency energy to gently heat the subdermal layers of the vulvar tissue.
Heat them up to do what?
Well, this controlled thermal energy creates microscopic damage, which essentially tricks the body into launching a localized healing response. The heat melts away the faulty, tangled nerve wiring and stimulates the fibroblasts to lay down fresh, healthy collagen and new blood vessels.
So it remodels the tissue from the inside out. It's forcing the body to rebuild the two-story house correctly this time.
Precisely.
And alongside all these physical interventions, cognitive behavioral therapy, or CBT, is heavily utilized. And I think it's really important to clarify here that suggesting CBT is not a doctor saying the pain is in your head, just think happy thoughts.
Not at all. CBT in this context is a neurological intervention. We established earlier that the brain physically changed its gray matter to expect pain, right?
Right.
CBT provides structured tools to manage the fear avoidance cycle, lower the systemic cortisol response, and actively help rewire the brain's emotional and physiological reaction to the pain signals. It is creating the top-down central sensitization, while the creams and technologies treat the bottom-up local nerve growth.
Okay, but what happens when you throw the kitchen sink at it and it just doesn't work? Like, what if a patient does the overnight lidocaine, applies the gabapentin, gets the Botox, completes months of physical therapy and CBT, and that car alarm is still blaring at full volume?
That is when the surgical option is considered. It is a procedure called a vestibulectomy.
Which, just going by the name, involve surgically removing the vestibule. That sounds incredibly intense.
It is a major surgical intervention, and it's generally reserved for patients with strictly provoked vestibulodynia who have completely exhausted conservative therapies. But the clinical data shows it has a remarkably high success rate, upward of 80% in some studies.
And honestly, based on the biology we've discussed today, it makes total logical sense.
It really does.
If the root cause of the problem is a localized physical overgrowth of nerve fibers that have broken through the connective tissue and penetrated the surface epithelium, then surgically excising that specific hyper-innervated skin removes the source of the false alarm entirely.
Exactly.
You aren't just treating the broken car alarm, you are physically cutting the wires and removing the siren.
Precisely. It's highly effective for the right candidate because it directly eliminates the core histological pathology. You remove the abnormal tissue, and the healthy mucosal tissue is advanced to cover the area, allowing the patient to finally heal without the burden of those exposed C fibers.
This has been an incredibly eye-opening journey into a condition that really lives in the shadows of the medical world. For you listening, if you or someone you love is navigating the frustrating, often deeply isolating world of vulvodynia, the absolute most important takeaway from this deep dive is validation.
Absolutely.
The pain you are experiencing is real. It is not psychological. It is visible under a microscope. It is a complex, documented biological cascade involving rogue immune mast cells, destructive heparinase enzymes, and structurally altered brain matter.
And returning to your specific concern from the beginning, treating related issues, particularly utilizing topical estrogen to resolve vaginal dryness and tissue atrophy, is a medically sound, deeply necessary step toward healing.
Right.
It restores the structural integrity of your skin and buries those exposed nerves. It is a tool for desensitization, not a cognitive hypersensitivity.
You are allowed to rebuild the wall.
Exactly. And, stepping back to look at the larger picture, this condition forces us to ask a really profound question.
Oh, for sure.
We have just traced how a simple, localized inflammatory trigger, like a routine yeast infection or a reaction to a laundry detergent, can initiate a chain reaction that physically alters the density of the brain's gray matter and permanently weaves a new web of nerves in the vulva.
Yeah.
If the human body can execute that kind of hidden, radical rewiring in the vestibule, what does this tell us about other mysterious chronic pain conditions?
Wow. Think about conditions that have similarly baffled doctors for decades. Fibromyalgia, irritable bowel syndrome, interstitial cystitis.
Exactly. Could understanding the precise cellular mechanics of vulvar vestibulodynia, the mast cells, the hit-and-run inflammation, the nerve proliferation be the master key? Could this hidden invisible pain actually be the blueprint that unlocks how we finally understand and treat central sensitization everywhere else in the human body?
That is a staggering thought. It completely reframes the entire conversation around invisible illness. Suddenly, that broken x-ray machine we talked about at the beginning, it doesn't seem broken at all. We just needed to realize that we shouldn't be looking for a fractured bone. We needed to be looking for a microscopic web of nerves grown from a forgotten spark of inflammation. Thank you so much for joining us on this deep dive. Keep examining the evidence, keep advocating for yourselves, and keep asking great questions.